Good afternoon and welcome to the first of our two webinars to present the new DHMH billing manual. My name is Nancy Smith and I'm partner in charge of the healthcare division of RSNF, formerly SHR Associates. Last fall, RSNF was contracted to create a basic and organized billing manual for the local health departments in the state of Maryland. Chris Perky and Hemik Patel, senior consultants with RSNF, were given this project, and with the input from MACHO, the AG office, and other members of DHMH, created this manual that I think, as you'll agree, far exceeds a basic billing manual. The manual is intended to provide the health departments and their staff with the tools and guidance to strengthen their internal billing processes and to serve as a legal and technical resource to assist the health departments in implementing and expanding their billing infrastructure in the most efficient and compliant manner. Chris and Hemik will be presenting today's webinar and will be introducing you to the manual and describing how to access and navigate through the wealth of information available. They'll also be reviewing chapters 1, 2, 3, and 5. I'll now turn the webinar over to your presenters, Chris and Hemik.
Hello, this is Chris Perky and Hemik Patel, and we welcome you to our webinar. A little bit of housekeeping notes as we begin the webinar. First of all, we are recording the webinar. We do have you muted, so any questions that you have, which we do welcome throughout the webinar, please type in on the screen that you have, and then we will answer each of the questions after each one of the chapters and sections that we go through. As Nancy mentioned, the manual is formatted in Adobe Portfolio. It is available on the DHMH website. We will provide you with that link at the end of the webinar. You do not need to purchase Adobe Pro in order to view this manual. All you need to do is have Adobe version 10 or above, which you can download for free over the internet. We will explain how to navigate through the manual and why we chose this format during the webinar. As Nancy said, we will do chapter 1, 2, 3, and 5 today. The other chapters, except for chapter 4, will be addressed during our second webinar, which will probably be scheduled in about 2 weeks. Chapter 4, which covers all the specific LHD programs such as STI, immunizations, HIV, reproductive health, etc., is planned to have a 4-hour in-person training session, and that you'll be notified when that will happen in the near future. Now I turn it over to Hemik.
Hello, Hemik Patel. We'll start with the manual here and the cover sheet. Up on your screen you see the first page of the manual, which is the Maryland LHD Billing Manual cover sheet. We've indicated the version of the manual as well. As you can see here, we're in version 1 at the moment. What we have, Chris and I have made a few updates since this manual was put out and submitted, and we're working on a version 2. We'd noticed that there were some things that had already been updated, so we had made those changes in the manual, so you will see a version 2.
Right, and some of the changes we've made, even though the one on the DHMH website is version 1 with date 3/1, as we've been reviewing it, preparing for this webinar, we've gone ahead and made those changes. So you will see them in this version that we have today, and we will be updating it and sending it to them.
We'll move on to the second page of the manual, which is the statement of disclaimer.
I'm going to enlarge the statement so you can see it better. There we go. It's one of the advantages of Adobe Portfolio, that we can make it larger, you can download it, you can copy it. The reason why we put a disclaimer is, like anybody else with a book with reference information, is information changes. So we want to, we've done everything we could to make sure when this manual is created that the information is up to date with COMAR regs and regulations. We've spoken to the AG's office, and they've gone through it. So at this point, we feel the information is accurate. At the bottom of the disclaimer page, we reference Allison Taylor. She will be taking any questions or answers that regarding the manual legally. We're not going to read every page of the manual because it's just too much. You can go back to that yourselves. Okay.
All right. The second page of the manual here, we've introduced and given some background information on the billing manual. In an effort to assist the local health departments in building a strong and effective and compliant billing infrastructure, DHMH had asked us to create this Maryland LHD billing manual. The manual will serve as a technical and legal resource for the local health departments for implementing and or expanding their billing infrastructure.
We mentioned that we've placed the manual in Adobe Portfolio, and the reason why we did that is, first of all, it is a reference tool, and things do get outdated, as we mentioned earlier. We also wanted you to be able to search for documents, which Henrik will explain how you can navigate through the portfolio and do that. We want you to be able to download documents, but since it's so large, you don't want to have to download the entire manual necessarily. We put in hyperlinks. We want you to, so that you can update the information as it changes. So we also did include a couple of webinars and PowerPoint presentations. They can be updated and put into on the manual as well. By not printing this also, it saves paper.
All right, so next we'll get into navigating through this Adobe Portfolio, and we've put a document here that really goes in detail on how we move around the portfolio, how we can use the search feature, look at the contents in a folder, how to open a folder, how to download documents within folders, and how to move between certain pages in documents. So it's a document that we strongly urge everyone to print out, especially when you're new to using this manual, because it really does help when you're trying to move through the portfolio.
And we realized some of you ahead of time were able to get the cover sheets, did get this navigation packet, and they also were able to receive the table of contents. So some of you may have that in front of you now, but Henrik is going to demonstrate how to navigate now.
So we have up here on the right, we have a search button. What the search button allows us to do is to type in something, and it will draw from the entire manual all the instances where the search has been found. And so for example, if we type in Comar in the search bar and hit enter, the portfolio pulls all the different instances where Comar is found, and we can scroll through all the different areas. And if we click on one here, for example, we have the Comar ability to pay and fees. And I'll just open it up as an example on how powerful the search bar is. It really does pull from all over the manual. And here it is. It pulled the Comar regulations just by searching Comar in the search bar. That's a pretty strong feature of the portfolio. Instead of having to go through all of the different folders and documents that we've listed, it's much easier at times to just type in what you're looking for. And again, it's pretty powerful in how it pulls through the whole portfolio. The second part that we did want to show everyone was how to look at the different contents in a folder. So if I scroll through here, we have all our different chapters in the manual. On the left side here, you see the different contents that we have inside this folder, creating the billing foundation. If you want to open up a folder, you double-click on the folder, and all of the different documents and folders within the main folder show up. To move between, so I'll click on one of the files here, proper documentation and accurate coding. I just want to use this as an example on how to move between the document and also within the folder. Down here you see that there's 4 pages within this document here. You also have the up and down arrows next to it. If you click down, it just goes through the same document, and it's very easy to scroll through. On the left here you have a show info view. If we click that, it'll show you the information that's within the file. And next to that we have a extract file. What this allows you to do is to download the document onto your desktop, and then you can print it, you can share with staff, you can do a lot more with it. So it's again very easy to extract the file. It's just by the press of a button right here. So going back to the pages here, if we were on page 4, we have a lot of other documents in this portfolio that have 100 pages or 200 pages. If we wanted to move back to, if we were on the 150th page of the document and we wanted to move back to page 1, there is the ability here for us to remove the 4 and just click 1, and it takes you right back to the front of the document. So again, very easy to navigate through. Double clicking again. So when you first open the file, it opens it up as a preview. We can double click it and it makes it bigger. It's much easier to read and see than it is in preview mode.
And at this point, you can also save it to your desktop, and most of the documents are in Adobe, but you can convert it or save it, modify it. It won't save it back to the portfolio, because what you've already done is download it into your computer, and that way you can make changes or save it however you want.
And then moving between files in this chapter, there's an arrow right here on the right-hand side of your screen that says Show Next File. If we click that, we're now moving on to the next document within the same chapter. So as you can see here, we're moving on to a chapter on NPI, but we're still within the Creating the Billing Foundation chapter. And we can keep scrolling through the entire chapter. If you see down here, we have a 2 indicated, and what that represents is the number of files within the folder. And I can show you that as an example. Here, NDC, we have 2 files that should be within the folder. We open it up and we have the two files contained within the NDC chapter. To go back, there's an arrow on the top left of your screen that takes you back to the contents of the chapter. And then if we went back one more time, it now takes you back to the main screen, which is where you can navigate between chapters within the manual as well.
Now we're going to go back to the table of contents. And I'm going to open that up. Today, like we said, we were discussing just a couple 4 chapters altogether. The reason we wanted to show you the table of contents and take a few minutes on that is because we want to show you how our thought process was in organizing the manual. So the first chapter is going to be talking about general information about the state of Maryland, about our government, about our counties, and that type of thing, explaining it, and also a little bit about the ability to pay, and we'll get fee schedules and all. We'll get a little bit more into that in a few minutes. But that's the first. We wanted to lay out what Maryland's all about. The second chapter we decided is, what do you need to build a billing foundation for the state? And again, you have the non-chargeable list, you have the sliding fee scale, and these other items that you also need in order to be able to bill and to get paid. So this is creating the foundation to get ready to bill. The third chapter is revenue cycle, and this we'll spend a little bit more time on when we get to it today. This is the revenue cycle. This is the heart of your whole billing, your charges, your payments, your documentation, etc. and reporting. We will be skipping chapter 4 today. This is a chapter where we'll be spending more time on when we have the in-person presentation in 4 hours. This is where we go into each one of the individual services of health departments. Now, your health department may not have all of these, but we try to cover all the ones that we've seen through the 24 health departments that we've visited. Billing related software. One of the questions we always have is, okay, now what's the tool we use to bill? So we decide, we put a section in here to talk about what a practice management system was, clearinghouse, that type of thing. We will be going over some of those today. Second webinar, we will be talking about Maryland payers, and this is where we're going to go into, we have a folder on the different types of payers like Medicaid, Medicaid MCOs, commercial payers, Medicare. We talk a little bit about each one of them. We have, for the most part, the manual, the administrative manual and billing manual for each one of these payers. The one thing that you will find is that's one of the things that need to be updated. We've got the most updated ones when we created the manual, which we worked on mainly in December, January. So some of the 2017 updated manuals haven't come out, and that's one of the things we're going to be looking at when we put the second version out when we're completed all the training. The section 7 is on contracting and credentialing, and of course you can bill. There are some self referral things that you can bill for, and the MCOs have to pay you. But for the most part, if you're not contracted with the payers, you're not going to get reimbursed. So we go quite a bit into this about the credentialing process. Chapter 8 is on compliance. We talked somewhat about billing compliance. We have the OIG, Inspector General's Federal Register. So we talk about HIPAA, we talk about billing, that type of thing, and even have a sample compliance plan that we've included. And the last chapter that we have is on resources. This is where we have some of the medical language, acronyms, glossary of medical terms, prior authorization information, claim denial issues. We talked a little about time-based coding. So some of the information in chapter 9 is also throughout the manual. So there are some times that we've repeated information, especially when it comes to the LHD programs. We may have something in here for STI, but we'll also have the same information in for reproductive health, because some of the health departments combine both of those programs, or other ones have it separate. So if you're focused in the manual and you want to go in and you want to just look at the information about your particular program, that you don't have to guess whether it's in something else or not. So we do recommend, like I said, that you print out the table of contents. We try to give you a little bit of detail on what's contained in each one. So when you go to use the manual, you'll know pretty much where you want to go, what you're looking for.
All right, so the first chapter of the manual, as seen in the table of contents, is the Maryland General Information chapter. And we'll double-click the folder here to get into the contents of the chapter. What we have here is a cover letter as the first document in the chapter. We've listed out the different, what we've put in this document is the different counties in the state, and really try to identify the home rule and charter forms of government, like the counties that have a ratified charter form of government. So if there's great information in here, we figured it would be a good place for us to start with the general governance and structure in the state of Maryland.
And the reason this has come up before is because when you go to contract, the state has tried to get state contracts with the payers, and so far the only one they were able to get one is United Healthcare. And a couple of the counties had difficulty signing in on as a group statewide contract because of the way their county governance was. They have to have approval from the board of directors, and they have different channels that they have to. So that's the reason why it's come up before and why we've included this in the manual so that you can understand why sometimes there's a barrier to your county to getting credentialed or contracted with the payer if you have to go through the legal system. We also have the link. If you double click it, this will go into the different counties and the different governments so you can find additional information, more specific. We didn't want to include too much in the manual. We just wanted to give you enough so that you know where to go if you have a deeper interest in it.
And right from there, we can continue scrolling right. We've included a map of the state with all of the 24
local jurisdictions
and the health department. So it gives you a nice picture of where the different counties are and geographic location for some of the health departments.
And I'm kind of jumping ahead, but one of the reasons this is helpful too is that you're basing the fee schedule for the local health departments on the Medicare fee schedule, 150% of what the allowable is. And the reason I mention that is because Medicare has 3 jurisdictions in the state of Maryland. So depending on where you geographically are is depending on how DHMH is determining what your fee schedule is. So the counties that are like PG County, Montgomery County, that are metropolitan near DC are going to have a higher fee schedule than the ones in Western Maryland and in the Eastern Shore, where Baltimore City has a 3rd different fee schedule. So just a little bit of information on why that's kind of important. These different jurisdictions also had something to do with the Affordable Care Act, how they were being managed when they were determining insurances. This document that we decided to include, the Senate bill, it came up that about the authority to who could retain the money that you generate from your health departments, whether it goes back into a general fund, who gets it when you're billing for all these services. So one of the health departments is kind enough to send us a copy of this, and we included it on it. You can read through it, but it does describe, why, what the law is that says that you can retain those fundings within your county. This COMAR regulation, we decided to include it too because this has a lot to do telling you that you do have to bill and collect for services and gives you a little bit of an outline. We included the COMAR regulation that has inpatient only because you do have 2 inpatient facilities within the state of Maryland for substance abuse. So we left that section in. And then the outpatient community-based services, we decided this is very important for your local health departments for day-to-day billing. And it talks about that you're supposed to charge patients for your services, and it discusses about the ability to pay fee schedule, and that the secretary from time to time will update and change that, and it's based on income and also based on family size. So you can look up again, you can look at the COMAR regulations, read more about this regulation at your leisure, but we just wanted to point it out because that does have an impact on your revenue cycle. The other item that we wanted to make sure we included is that the local health departments are considered an essential care provider. Originally when the Affordable Care Act came out, they were not considered an affordable care provider. Since that time in January 2016, this was amended, so it does give you some leverage. Some of the health departments have had problems getting contracted with the payers, but being the status of an essential care provider, it does give you a little bit more leverage if those services for those the lower income, underserved patients do not have access. They do have enough providers to cover that in their area, then they need to contract with the health departments. And we decided also that the MHO was instrumental in helping us with the submitted questions, and we tried to address them in the manual, just like the Attorney General's office. So we wanted to recognize who MHO is. We thought this would be helpful as a tool. This is 2017, the list of the president and all the changes. Again, if you want more information about NACHO, you can click this on, but they have been instrumental in helping the feedback for the manual. Okay. Are there any questions? No questions have come in? Okay. So we're going to proceed to creating a billing foundation. Okay. The reason this section is so important is because you need to make sure there's certain things in place, like I mentioned when we were introducing the chapters, that have to be there before you can actually do any billing. So what we decided to list here is NPI numbers. I think everybody realized NPI numbers are national provider identifiers. There are three types of NPI numbers. There's organizational, there's subpart, and there's individual providers. Your health department has an NPI that's the organization NPI. If you have multiple locations, you may need a subpart NPI number that goes underneath the organizational NPI number. We will have more information on that within the manual, but what's important is that your claim won't get paid or processed if you don't have the NPI numbers on it. NDC codes, the reason that's important is those are national drug codes, so if you do any injectables or immunizations, if the NDC number is not on the claim form, you will not get paid. Federal tax ID number, obviously that has to be on the claim form. Place of service codes, where the service is being provided, has to be on there and then on the claim. And in most cases, you will be using a 71, which is for local health departments, but there are also codes for inpatient facilities. Taxonomy codes are important because they describe what type of specialty that your clinic is. The health department has a taxonomy code for health departments, public health, but also within the divisions, if you have some reproductive health, they'll have different taxonomy codes. CLIA numbers are numbers that the federal government for lab that you have to get approved, that you're either a microscopic lab or what type of services you're performing, you get a license, or whether it's wave test or whether it's high complexity. So CLIA numbers, in order to get paid, that has to be on the claim form too, in order to get from the government payers for them to pay you for any lab tests that you do in-house. We also have in this chapter information about documentation and medical record standards. They have to be followed. We talk about self-pay collections, sliding fee scale, and of course the non-chargeable list. This document, this COMAR regulation, describes how the health department's fees are set. This changed a few years ago, and so this actually goes through it about assigning CPT codes, and it's 150% of the Medicare participating provider fee allowance. So I'm not going to go through this whole thing and read it. I think most of the health departments understand this, but if not, we just wanted to make sure that it was the COMAR regulations were contained in the manual. And this everybody's familiar with is the non-chargeable list for the fiscal year 2017. This is the DHMH's sliding fee scale. This is 2016. It's the most recent one we could find. We will see if there's another one before we, for the version 2. It tells you about the income. It tells you what you're allowed to charge the patients based on that. This is the 2017 federal poverty levels. They haven't changed that much since 2016, but we did conclude that range. This tells you a little bit more about the taxonomy numbers, and this hyperlink you can go right to the website to be able to look up taxonomy numbers and download it. This is the CLIA, which is the federal state waivers and microscopic procedures and how to register for your CLIA certificate if you're doing any lab procedures within your clinics. And here's the hyperlink for more additional information in how to obtain your certificate. We've also included the list, we just put in the other day, the list of wave tests under CLIA. So you can look up like the microscope, the dipstick, almost every clinic is using that for some capacity. And so that's a wave test. Sometimes some of them are doing the blood glucose. So this gives a comprehensive list. Again, this will be found on the CLIA website so you can see what classification you fall in. This is microscopic test, like that we would have to have that level of CLIA certificate. And this little comprehensive little brochure gives you additional information from the CDC. And again, just click on it. That pretty much summarizes the first two that we just showed you. And then we even included the application. Go back out. This we included because it talks about proper documentation and accurate coding and why it's important. Once you start participating with the payers, you are subject to audits, and you will have an audit at some time. And what they do is they look at the documentation and compare it to what your level of coding was. And this is very important that you're compliant, because they can get penalized or they can take money back for what they paid you for. We've included the link to do the 95 documentation guidelines or the 97. And the health departments that we've come out and done training on, we've explained the difference between the two. And we do have a document that goes into real detail in the grid that shows you how to be able to, either go under either one of these guidelines. And we also explain what an E&M code is and patient type, and then the NPI. So again, we go into more detail and modifiers. This folder goes into the NPI identifiers, like I just mentioned, what it is, what it looks like, and also again where you can obtain one. A lot of the health departments have needed subpart NPI numbers because they have multiple clinics. And this is a really good resource from CMS, Medicare, explaining again about all the different NPI numbers and where to go to obtain them. This one explains about the subparts that I mentioned earlier, which a lot of the health departments did not have subparts, which means if you have multiple clinics, each one may have to have it at different locations in order to get paid because they're different services. And we got an NPI. Sorry, we just did that one. I'm getting mixed up myself using this. The NDC numbers. NDC numbers is what I mentioned earlier that have to go onto the claim in order for you to get paid for your injectables. And when I mention NDC numbers, I also want to emphasize that you also need to make sure the right number of units when you're doing injections. This is where you can look up the NDC numbers for vaccines. NDC numbers appear on all of your packaging of your drugs. And you do want to make sure that you have the right NDC. It's not uncommon for a drug to have multiple NDC numbers, and the reason is that it contains what the packaging is, who the manufacturer is, and the number also identifies what the drug is. So you may have a vaccine that there's 3 different manufacturers, and if you don't have the right one associated with the right drug, you could be billing incorrectly, but also, especially if it's a DFC vaccine, if you're using the wrong code, the payer won't pay you if it's a Medicaid or MCO. And then we just basically go into a little bit about tax ID numbers. Most of the health departments do have those. You will sometimes be requested, some of the payers may request an IRS form to prove, or they definitely will request a W-9, and so you may have to provide that information. So we included some information about W-9, verification on the W-9 form, and W-9 instructions. There we go. Are there any questions regarding this chapter? Okay, does this section on waiving fee address hardships? In the past, health officers were able to grant either medical or therapeutic hardships. Is this still permissible? There is information about that in here, that the health officers do have the leverage for their health department on the general population. I will have to find, I believe it's in this one. No, it's on, I will find that and tell you exactly where it's at. But there is hardships, it depends on whether you're talking about a global hardship. Again, so all this, that they can write a waiver for certain things, but if it's something that is not global, it's on an individual basis. So if you have somebody and they've been fee scaled and they really do owe that amount of money, then you do have the health officer has the discretion of waiving that fee, but it needs justification. We will go a little bit more into that at a later time in another chapter, but we will make sure that information is available to you in more detail. Second question, the CMS CLIA information is helpful. If the state lab license information is not included, then I would recommend adding it. We can do that. The third question, if there are criteria or a process for determining the permissible types of hardship waivers, blanket individual, that would be helpful. And that we will provide you that information. We'll get that together, and at the next webinar, we'll make sure we present that.
All right. If there are no other questions, the next chapter that we'll be moving on to will be the chapter on revenue cycle management, which, as Chris mentioned earlier, is the heart of our presentation. There's a lot of good information in this chapter for the different processes in the revenue cycle, and we've included several tools, including training guides, to help the health departments use with the staff that are part of the revenue cycle. The first document here gives us an overview of the revenue cycle. The revenue cycle starts at the front desk. When a patient walks in and registers, it's the front end that's responsible for collections, for recording and verifying patient and insurance information, collecting any co-pays and outstanding balances, and for collecting all their referral requirements. It's critical to understand that the front desk is a big part of the revenue cycle, and it does start at the front desk.
It also includes a sliding fee scale in most cases, because beyond what a private practice would have, with the local health department, you need to often obtain documentation of proof of income. So the sliding fee scale is also an important part.
The second part of the revenue cycle is the clinical coding and documentation. Documentation must be accurate and complete to support the clinical services provided and coded. We've included a quote here: "If it is not documented, it did not happen." That's how critical the coding and documentation piece from a provider standpoint is in the revenue cycle. The documentation is really proof that the services that we've indicated we've rendered were actually rendered. Again, the coding and documentation is done by the providers and then reviewed by the billing office later on in the revenue cycle. The third part of the revenue cycle includes the checkout processes. This is where charges are captured, any collections that have not been made earlier in the process are now collected, and reconciliation of the day is also done at checkout.
Sometimes the health departments, because of the structure or the way it's set up, the front end and the back end are done together at the same area, but also some of the checkout may be done by the fiscal department or by a biller. So it just depends on how you're structured. The main components, like Hemmick is saying, is you have a front end, you have to have all those components, and the clinical, and then we'll get into the billing.
And we've included, you'll see later on in this chapter, more specifics on some of these front-end processes, and again, different training guides that you can use with the folks at the front end in training them on some of these activities that are done at the front end that relate to the revenue cycle. The fourth part of the revenue cycle is the billing office processes. This includes reconciliation, charge capture, payment processing, claim reviews and processing, also managing denials. When insurance companies deny our claims, it's critical to manage those denials and appeal those claims and work your accounts receivable. So you see here denial management, appeals and accounts receivable management is a critical component of the back-end work. Claim submission is one part of it. But a lot of times, again, insurance payers, they don't pay you and they do deny your claims. So having someone that's really managing those denied claims and appealing those claims really helps your accounts receivables. And we'll talk a little bit more about the different KPI metrics that we use to measure the effectiveness of the revenue cycle, to include all four of these different processes. But just wanted to just mention here that denial management was critical. Also part of the billing office processes is submitting patient statements, the collection activities, running reports, report management, payer communication, and that's keeping in close communication with all your payers, and following up on claims that have been submitted or appealed after denial. And also another key part of the billing office is providing feedback to your providers and to your staff regarding your revenue cycle management issues. From a provider standpoint, billing office is responsible for providing that feedback to your providers on how their clinical coding is, how their documentation is, and areas that they can improve to better their coding and documentation, which effectively maximizes their reimbursement from payers. If they're coding appropriately and providing that documentation to those services, then the reimbursement will be higher. And also providing feedback to staff regarding any revenue cycle management issues that they see, because again, it's critical to see here that the front end processes are just as important to the revenue cycle as are the billing office processes. So providing that feedback to your front office team is very, very important.
Yes, the majority of the denials that we often see is because the information hasn't been gathered and recorded appropriately from the front end. Like the wrong insurance company information or name or code, or that they don't have the right billing address, and et cetera. And then, of course, the sliding fee scales. So those are very important. That we do realize that some of the health departments still do not have a practice management system to help them to be able to look at their AR and process it. So that's an obstacle, which again we'll address later when we talk about practice management systems. But that can be a really major issue on your revenue.
And Chris mentioned the practice management system. We've included ways to reduce some of the revenue cycle issues, educating your providers and staff regarding all the processes in the revenue cycle and how they are interrelated throughout the clinic and practice is important. Sometimes practices and departments fail to realize that the front end, the clinical coding and provider piece, and the billing piece are all connected, and they're all part of this whole revenue cycle that we're speaking of. So educating your providers and your staff regarding that is important. Investing in a good practice management system, Chris mentioned, something that's easy to use, really has what we needed, what an effective revenue cycle requires is important. And in a later chapter, we do go on to talk a little bit more about what we feel is our key features in a practice management system and how to select a powerful practice management system. Choosing a robust clearinghouse that permits verification of insurance coverage and benefits, provides claim scrubbing and claim denial management, allows electronic remittance advices. Your clearinghouse is important as your scrubber, and it really allows you to submit cleaner claims to your payers. It's your middleman, if you will, between the health department and the insurance payers. And what they do is they really scrub your claims and make sure that you're submitting clean claims to the payers, which improve your chances of getting paid in a timely fashion. Also, it's important to make sure that you choose a clearinghouse that allows electronic remittance advices, and those are essentially an explanation of benefits form in your system, which is much easier to read. It reduces your paper in your office, and really is, again, an effective component of the payment piece of the revenue cycle.
We have a question we might as well address right now instead of waiting until the end of the chapter. Someone wants to know the difference between the PM system and electronic medical record. PM system is a practice management system, and basically that handles your financial, stores your insurance information. Typically, it's your registration, your schedule. Even though some of the EMRs, electronic medical record programs, can do that, your billing component is your practice management system. Your EMR is your electronic health record, which is what's storing the patient record and all their medical information. So typically, before electronic medical records came out, they were just practice management systems. You did the billing, everybody kept a paper chart, and some people are still doing that. So that's your practice management system, where you can do your billing, do your claims, do your AR, do your reports. When EMR came out, some of the practice management systems started integrating it and having it as one unit, but having separate functions. Other ones, they were combining them and just interfacing them. So those are not quite as efficient programs as the ones that are fully integrated. And we can go into more of that later. But basically, EMR is your electronic medical record, which is also called the electronic health record, and the practice management is for billing. I will also explain what the difference between EMR and EHR is. Back in the day when EMR came up, electronic medical records, that was primarily used for medical practices. But it goes beyond EMR. It goes into health record, which contains lab, radiology, mental health, and even dental. So it's not just the medical record, it's the whole health record of the patient as things start getting imported. And that's why you'll see the term EMR starting to go away, and you'll see EHR come in.
And there will be more information on the differences between the practice management system and the electronic health records, and how to select appropriate practice management systems and EMR systems in the next chapter that we have.
That we're getting ready to do.
Going off of the practice management system, we've included here educating and training at least 1 or 2 staff members to be practice management system super users is important, because this allows you to have an expert internally on the practice management system. And by super users, it's not only just the rights that they have in the system, but it's the training that these folks have been through with the practice management system that allows them to do a little more than your folks that have just been trained internally on the system. So we strongly encourage selecting 1 or 2 people internally to become super users, to go through that training, and also to go through ongoing training on system updates, on things that change within whichever system you select, because it allows the health department to have someone that has a strong understanding of the system.
The reason why, and Henry's right, typically we see it like a billing manager will have super user rights, and the reason why is they have to maintain the codes. They have to make sure there's modifiers. They can also, sometimes if you have a sophisticated system, you can write rules in the system saying, okay, United Healthcare, this is a true example, United Healthcare won't do an office lab procedure like a dipstick or a urine pregnancy test, won't process that claim without an ET modifier on it. Well, that person can set up the system to do that. Now, some of the health departments, as we've gone out, we know that their IT support, and typically IT used to be just hardware, setting up the hardware, making sure everybody's printers, scanners, and everything can work. But it's extended beyond that. Sometimes with the IT departments have become very sophisticated in helping with the practice management and EHR because it's so complex. But a clinician knows more about setting up the templates for them to do an EHR for what they're going to need in their clinic because of an STI issue or immunizations. So having somebody that really, a couple of super users that can keep the system going, and obviously you have to have controls on it, is extremely important. And we do realize some health departments don't even have a billing office. So sometimes the front desk people have gotten designated to do that.
And going off of that person, our next bullet here, could also verify and update that the PM system is updated with the correct codes, fees, and different specific payer nuances as needed. So having that super user really allows the health department or any organization to really do a lot more with the system. More ways to reduce revenue cycle issues, having an internal written financial policy and having it reviewed by legal counsel. Make sure each patient signs and receives a copy of this policy we feel is very, very instrumental. Financial policy should include information on the clinic's policy of collection of co-pays, deductibles, unpaid balances, patient financial responsibilities, supplying insurance information, types of payments that are accepted in the health department, whether that's cash, credit cards, checks, debit, etc. Information on the self-pay sliding fee scale.
And one other thing we want to add, we know that the health departments have to see the patient. It doesn't matter on their ability to pay. So obviously that would be your bottom line on your financial policy.
Mm-hmm. Having a clear written policy and procedures that addresses billing compliance and revenue cycle management issues such as payment collections, reconciliation processes, charge entry and charge capture, how to address bad addresses and bad checks, bankruptcy notices, refunds, claim processing, patient statements. A policy coupled with the policy that we mentioned above, a financial policy, will really make you stronger internally with the revenue cycle and allow you to make sure that you're communicating appropriately to your patients, and the information that we have internally is transparent as well. So we strongly urge the development of these two policies for health departments.
There are some health departments that have really good policies in place, and it's nice that they are willing to share them. I know there are a couple of health departments that are willing to share them with the other health departments. The other day I was at a meeting with the health department, and they're having sub-committee meetings for different departments like reproductive health. STI does the same thing, where the different local health departments support each other, and they're sharing common denial issues with payer denials. So all those different things help strengthen the revenue cycle, because you're going outside of your health department. You're going, in sharing, because even within your health department, the reproductive health is going to have different issues in immunization when it comes to denials and insurance payments.
Conducting ongoing provider and staff education on proper coding and documentation. When your providers are audited and the documentation and coding is looked at, providing that feedback on where your providers can improve with their coding, can improve with their documentation is important, not only because you can maximize reimbursement that way, but also from a compliance perspective. So making sure that there is ongoing provider training and staff education really helps reduce some of your revenue cycle issues, and also helps improve your revenue cycle.
Understanding payer contractual obligations. Now, some of the health departments have been real successful in getting contracts, and other ones are still struggling. Payer contracts, there are certain things that you do need to do within your health department in order to be compliant. So we really recommend that you understand your contracts, and that you communicate that to the front desk if any of those contracts relate to what the data that they're obtaining. Also, the payer, understanding and monitoring the contractual payer fee schedules and validating the reimbursement that's compliant with your contract. I often give the story that I was managing an anesthesia department for a huge hospital as a consultant a few years ago, and their management that did the contractual arrangements with the NCOs and with all the insurance companies, they had made a great arrangement and fee schedule reimbursement, but yet they didn't give that information to me in the anesthesia office. So when I finally got a copy of the fee schedule, I realized they were paying several $100s less per code than what they were contracted to do. They had never loaded the new agreed contractual fee schedule in the system, into the insurance company system, so that we get reimbursed appropriately. And this had gone on for a couple of years before I even started there. So I just want you to, it's very important to know your fee schedules. If you have a robust practice management system, you can load your fee schedule into the system, so that when reimbursement comes, that your billers and whoever's posting the payments do see, because it'll flag it, that you're not getting reimbursed what your contractual rates are.
One of the last parts of the revenue cycle is the payment posting part, and monitoring that charges are being posted correctly is important, and making sure that the patient financial responsibility is not being adjusted off really helps in again, maximizing your revenue cycle, making sure that you're getting paid for what you need to get paid for. Claims being appealed appropriately in a timely manner. Typically there is someone internally that is responsible for following up with your payers and communicating with your payers to follow up on appeals, to see where they stand with appealed claims, and doing that in a timely manner. Sometimes we've seen different ways of doing this, whether it's through monitoring this through spreadsheets or again, if you have a robust reporting system, there are some great reports out there that can help you track appeals and really create a system where you can follow up with appeals in a timely manner. So
you can tell the denials by the pattern. So if you record the denials by a particular denial code, you can start seeing patterns. Somebody, either billing manager or administration, if they are doing those reports and reviewing them, they're going to be able to see a lot of things that when you're too close to, you can't when you're doing it on a day-to-day basis. So just like Henry's saying, getting those systems in place is extremely important to make sure your revenue cycle, because if you have timely filing limits on how often, when you can file a claim, 6 months for your Medicaid MCOs, Medicare and Medicaid allow you a year, but when they deny a claim for some reason, the denial, it resets the clock, and you may only have 90 days to appeal it once it's been denied. So paying close attention to that is very important. Another thing with the denials is that most practice management systems have a scrubber within them themselves. They can tell you, okay, they're not even going to submit the claim because you're missing a modifier or the code's no longer valid. So those things, when you work your own system, they're going to identify those so the claims didn't go. But a lot of the claims, when they go to the clearinghouse also has a scrubber. And consequently, they're going to say, we're not going to even put the claim through to the payer because you have these errors. And then on top of that, the payer may not even put it in their system if it doesn't pass their scrubber. So there's different, places that claims are being looked at and scrubbed before they even get to the payer. So you need to be sensitive to that. Okay?
And the last 3 bullet points we have here, we will be touching on these when we talk about the key performance indicators, which are used to again, measure the effectiveness of your revenue cycle. But it's important to work your patient and insurance accounts receivables, and this is the outstanding money with whether it's the patient or the insurance payers. And as Chris mentioned, when there's money sitting in this bucket for a longer period of time, it only becomes harder to collect. So having someone dedicated to working your patient and insurance accounts receivables is important. And we'll talk about the standard reports and the different KPI metrics in the next upcoming chapters.
We will mention one more thing as far as payments are concerned. Most of your payers now, Medicare, Medicaid, they are requiring that automatic deposit right into your bank accounts. And this can be confusing and a problem for health departments, because when the payments get in, how do you match it up with the EOB and the electronic remittance advice? So we always recommend that you keep a log, and that whenever you're getting an electronic remittance advice or an EOB, especially electronic, that you match it up to the bank deposits, because we have seen that the bank will have money deposited in it that you've never gotten the explanation of benefits from the payer or ERA from, or that you've got an ERA or an explanation of benefits and you never got the money, it got channeled to someone else. So you want to be very, very careful about that. Also, the practice management systems, if it's set up correctly, if you get a general payment that's inclusive of multiple departments within your clinic, within your health department, the practice management system will be able to sort out once the payment's posted. You don't have to go in and make sure you post it to this clinic or that, because the claim number, the claim ID is identifying in itself where that service was provided. So you would be able to get a report out to say, okay, I want all the charges for immunizations, all the payments and adjustments for immunizations, and that would all be attached to that claim number, and you'd be able to do that reporting. We know that a lot of times we go into health departments that it's all done manually on spreadsheets and all. Getting a practice management system that can work for you, but also understanding all the features and what you can expect from it is important, because often there are features and things available, but the health departments don't know about it. So again, that's a good reason for having super users.
right, so the next document we have here is a revenue cycle management process duty sheet, and we've included this in the manual as a tool for the health departments to use to see where some of the activities in the revenue cycle belong, whether they belong at the front end in the reception area, the clinical with the providers, or at the back end with the billing and accounts receivables team, or with the administrators and directors of the health department. So we've listed out all of the activities in the revenue, most of the functions in the revenue cycle, and again put them in the appropriate area. But this can really help and can be used as a guide to determine A, if your functions are being performed in your health department, and B, if they're being performed by the right area. A lot of times we see that billing is doing things that the front end should already be doing, or billing is doing things that, or administrators are doing things that billing should be doing. So this really just helps as a guide for the health departments to use in making sure that your duties are identified in the correct areas as well.
And what Hennick and I have done is when we've gone to health departments, we've actually had a chart up and we say, okay, these are the functions now. Let's associate them with who's doing it. And then you'll often find out nobody's doing some of the functions. Or that look how heavy it is that Jane Doe at the front desk is doing everything. You really need somebody in billing to handle some of those. Plus it's part of the reconciliation. So it was a nice tool, a good exercise that gets people involved. And you would be surprised when you work with your staff on some of the things that they're doing in the load of work that they're doing. So.
And one thing I wanted to mention, going off what Chris is saying, is sometimes staffing varies between health departments. Staffing varies in certain departments. So some of these duties can be shifted, but we just wanted to give a guide on kind of the best practices of where some of these activities belong. But there is flexibility, and some of these can be moved depending on staffing in each of your health departments. We do understand that staffing varies across all health departments.
And even the titles of what you call somebody at the front end can change. The billing accounts, fiscal, that type of thing. So again, we've tried to be a comprehensive list of what need to be done for a good revenue cycle. But like Henrik is saying, it can vary depending on how it's set up.
This is a nice guide that really shows the revenue cycle management process from front to end. We've included this because it's a nice visual, and it shows us that the revenue cycle does start at scheduling, followed by the pre-authorization eligibility, reminder calls, registration check-in, eligibility verification, capturing the charge and coding, checkout, and then the back end you have the claim submission to clearinghouse, payment posting, remittance advice, following up on your claims and working your accounts receivables, submitting patient bills, and then quality improvement, the benchmarking and auditing. So it's a nice visual of the front end processes, which are in blue, your clinical process in purple, and in green you see your billing back end processes, and then in red you see your quality improvement process. So we included it in the presentation to give kind of a snapshot of the revenue cycle.
Yeah, Cardia does a really good job of having some great reference tools, and I contacted them and they have no problem with us sharing this information. Matter of fact, they were happy that that we were able to pass it on. And again, they don't have everything. Like when you go into registration check-in, it's not going to go through. They need to scan the insurance card, or that they need to do the sliding fee scale or collect information about their income. But this is really a nice guide, and there are additional explanations of each one of those categories. That when it talks about charge capture here, it just explains a little bit more about it. So it's a really nice tool and another reference point for you.
And also it can be a great education tool with your staff is on the second page that Chris was showing here, it shows you the revenue cycle step here on the left, what you can do to complete that step, how it helps the organization, and what would happen if you don't complete the step. So really using this also as an education type of material with your staff can benefit the health department. And again, just to mention, it's I know we talked about this earlier, but you can download the file right from the page here where it says extract file.
Now here goes into a little bit of information. I know people have been concerned about waiving co-pays and co-insurance. And this is from the Office of the Inspector General. This is actually the compliance of third parties, because we have the links, actual links. They really frown upon you writing off co-pays if it's a patient's contractual obligation because they have a contract with the payer, and there are exceptions because of hardship, but they cannot be global unless the hardship, there has to be a reason for it. And there are forms and guidelines, and like we were saying earlier, we can provide some of those for you. I don't believe we have it in there at this point. We may have it in the resource. We've had so many at it. So I'm not going to go into a whole lot of detail about it. This gets really complicated. I spent a lot of time at one point with the AG's office even discussing this. But the health officer does have the right to say, for our population and our community, it's against the interest of public health to bill for this particular service, and they can write a waiver for that. So they do have that option to do that across the board, but not in their general financial policy.
The next folder in the revenue cycle management chapter is the front end. We've broken the chapter down by front end, coding and documentation, billing, and then the reporting section. So we'll go into the front end. And so the revenue cycle does start at the front end when staff and patients interact. There are several tasks that need to be completed at the front end, and developing these processes and workflow is essential to your revenue cycle. Whether the first contact with the patient is through a scheduled appointment or a walk-in, there's information that needs to be collected and verified by your front desk staff. Collecting incorrect information or incorrect patient demographics, wrong insurance information are common problems, but they're problems that lead a lot of times to denied insurance claims. A lot of times people think that claims are denied because of coding or documentation errors, which sometimes they are, but there are significant times where denied claims are because of errors at the front desk, and it's that much more important for us to focus our efforts with our front desk staff and making sure that they understand this process and are trained appropriately.
In most practice management systems, you can default and make them required fields, so your front office can't go any further without filling that information in. Doesn't mean they may not transpose numbers, but that is, something that you can put in your practice management system.
And what we've done here is included the different types of patient demographic information, insurance information that needs to be collected and entered into your practice management system, with scanned and copied, in order to have your comprehensive information for submission to payers when you submit claims to payers. Because payers will deny your claims if you don't have all your patient demographic information entered in, or you're missing some insurance coverage information in your claims.
And also with the health department, and when you're reporting to federal insurance claims, meaningful use is something you definitely want to be able to prove, and that so you'd have statistical data for all your patients, ethnicity, race, age range, that type of thing. So that's another reason, not just for the revenue cycle as a whole to get claims paid, but also to meet some of those other criteria.
So we've also included information on, we mentioned eligibility and benefit verification. How do we verify, how do we check eligibility? There are several tools that can be used to verify eligibility and benefits. We've listed a few of them here: EBS, Medicaid, going directly to your MCO websites or calling to verify coverage, checking their insurance ID cards. A lot of times patients receive new cards and it hasn't been updated in the system. So making sure that you have updated insurance ID cards in your practice management system is important.
Yeah, a lot of times patients, they may have the same insurance for 10 years and they get a new card each year, but they don't realize that internally the insurance companies change the prefix. Care First Blue Shield is one that commonly does that each year. So a lot of times they don't update it in their wallet. So that's the reason why you want to even inform the patient sometimes, because if you use the wrong prefix, then your claim's not going to go through.
And also going directly to your payer websites to verify eligibility and benefits. There are a lot of practice management systems that form electronic eligibility on their system within the click of a button, and it gives you their eligibility information, and it's
sometimes often benefits information too. Clearinghouses do eligibility verification, and then, IVR by phone. Novitas, which is your Medicare for the state of Maryland, you can also go online and check eligibility with them. But the easiest way is the practice management system, because they'll even use EVS in most cases, and almost every practice management system does have that feature now. There is sometimes a cost associated with it, which you'll want to check with the vendor that you're using to see. This is a sample of a patient registration form. And the main reason we put it down on here is to realize that the LHDs, they need to include information about CCU, the Central Collections Unit, and that there's a 17% fee that will be tacked on to the patient, and they'll have to pay for it. And they need to realize they need that disclosed to them initially. So when you collect patient information, you always have to have, at least on an annual basis, a signature allowing you to submit the claim for the patient to the insurance company, and also that they disclose it. And that's part of the financial policy, which you can have separately included, but it's very important. This again is a sliding fee scale. We showed you earlier, again, like we said that we have it in a couple different places for you.
This here is a front office training checklist. Mentioned that there are several tools in this presentation that can be used to train your front end staff. This is one of them. We've listed out the different tasks that need to be completed at the front end with scanning the phones, fax, copier, computers, check-in, check-out, credit card machine, and what needs to be done at the end of the day. This can be used to really evaluate each of the folks that are at the front desk that are collecting insurance information. And
it's great to use for orientation purposes, that you've shown them and that they've done it satisfactory, and employee initials it in that way. If later on they say they were never shown how to do it, it also gives you a bit of confidence on where your staff is in their knowledge base. And this can be modified. You can just use its format, and also they can do it not just for front end. You can create something like this for billing even, or the clinical. Okay, this section is on coding, the clinical responsibility, coding and documentation. We mentioned earlier about how important it is to for the clinician to document all their work in order to justify the level of code that they're billing. You know, we don't want to go a lot into the coding piece here. We've tried to provide that in the past when we come out to the health departments, but there are basically, like I mentioned earlier, 95 and 97 coding guidelines. The clinician, if you have an EMR, EHR, usually there are templates that are set up, or you can set them up, and that way you can check off the boxes to be compliant and have some pre-text areas also. And this is the reason why you need to have medical records, the ability, you know, to evaluate and plan the patient's immediate treatment, better manage the patient's care over time, to communication for the continuity of care. We're seeing more and more health departments doing some care coordination, so being able to communicate that information even within the health department itself. It's very important that your documentation is done accurately and timely. You should not be submitting a claim unless the documentation is complete and signed off by the provider. The appropriate utilization review and quality of care evaluations. We recommend that you do internal audits. If not, get an outside company and do it at least annually, if not 6 months. So that sometimes it's peer-to-peer review where you're looking to make sure that the documentation and the coding matches. This is something that I'm going to go down here to. This is the NCQA guidelines for medical record documentation. And obviously this was when it was more like paper charts, but it's still applicable today that you want it in your electronic. I'm not going to go through each one of the lines, but you can see here in the past medical records, these are the typical guidelines that you're going to find even in your provider contracts with the payers. They will usually have what their guidelines for medical record documentation records are, and it will be almost verbatim what this is. So I wanted to make sure I explain that. And this is where you can find additional information about documentation and coding. The Medicare outreach education, they are excellent with providing, and we do have that manual in here downloaded. One of them, I'm going to click that on right now so that you can see it. Again, we have the hyperlinks. It just takes a second for my computer to bring it up. Here we go. So by clicking that link, this is what I was able to obtain. This is talking about the EMM codes, which are evaluation and management codes. It gives you the 95, 97 guidelines. One thing that HMH and I will always recommend to you is to get on some of these payers, get their newsletters, get on their website, so automatically be sent to you as things are updated so that you can keep track of them. I'm not going to go a lot more, but this is this whole manual is available. So there are so many good educational teaching tools available. Let me do this. Okay. This is a common problem that we see in some of the health departments and medical practices is about the 99211 checklist, or when can you code for a nurse visit and when can't you? So this is something we found on the Medicare website and also this website. And it just gives you a guideline as when it's okay for you to charge for a nurse visit. And now the health departments usually have standing orders written, and it's either the deputy health officer or the health officer or the medical director. And so there is information about what the scope of practice can be for that. This is typically an RN medical assistant that is providing some services that sees an established patient. And again, these are the requirements in order to be able to bill that code. This is the brochure I just brought up. We did download it. There's 9 pages. Great information. This is Novitas, which is, again, Medicare, like I mentioned. That's the vendor that does manage Medicare for Maryland. And when you go here, this is going to show you, like we were talking earlier, this is the E&M auditor's instructions, so you can see whether you meet this criteria, the different level of services, medical decision making. Again, we won't go into a lot of detail, but just want to make you aware of where that you can find this information to be able to evaluate. This is extremely helpful, this information, to your providers.
All right, the next chapter in the revenue cycle management chapter is the billing component. But before we get into this, we did have a few questions that we wanted to address.
Is there a standard statewide form or format for clients to declare no income? What documentation is required, or should you just accept the patient's word? It depends on the program. If you're in Title 10, you're supposed to have proof of income if that's the policy that you have. If you're getting immunizations, if you're using VFC vaccine, you do not have to have proof of income. So we'll get a little bit more into that when we do the section on the different LHD programs. And unfortunately, it just gets more complicated for your staff at the front desk. So having cheat sheets to tell them, okay, if they're in this program or that, what guidelines that you have to have. Brian White, if you have HIV and you're having funding for that, that's a whole different way of handling things too, as to what you need proof of income and what you don't. But I will tell you, Ryan White and Title 10, unless it's confidential, patients, if they have insurance, you have to build the insurance first before you can use the funding from the Ryan White or the Title 10 program. Second question, so is there a way to download the entire presentation? You can't do from the DHMH link provided. It's something we'll check with DHMH. It may be that you don't have Adobe version 10 or above loaded. Maybe that you don't have enough space on your computer. That's one thing that maybe we can talk to you more later after the session and find out what the problem is. So to go off Chris's answer, it could be related to the Adobe that you may have on your computer, but I did want to show you that each of these chapters, I know we showed you how to download files and documents within the chapters, but if you wanted to just download the revenue cycle management chapter and all of the contents within the chapter, there is an extract folder button here. And what this will do is it'll extract and download all the information, including the sub-chapters and presentations and documents within this entire chapter. So there are folders here that have more information than just one or two documents that you may want. It may just be easier for you to download the whole folder and then sort it that way. But if you can't open it at all, there's that can be a problem too. So we will look into it. We see your second question about downloading it and how difficult it is to download it. We will look at that because we have had people when we had it in the Dropbox, we're even having difficulty downloading it. So we want to make sure that you can have this accessible. So if you can send us your email or contact information, just type it in and we will get back with you.
All right, moving into the billing process of the revenue cycle.
We went over some of it already.
We did touch on a lot of it, so we'll go through some of this here. The billing office, of course, it's a critical part of the revenue cycle. They're responsible for keying in charges into your practice management system. A lot of your practice management systems have great tutorials on how to key in charges specific to the system. The general process is the same. You want to make sure that all your charges are being captured and entered into the system, but each system is a little bit different on how to enter in your charges.
And often, if you have an EHR or EMR, then your charges are coming over directly from your medical records. So you don't have to manually put them in. So, but you still need to look at and make sure they're all captured.
We mentioned a couple of the key things here to review and correct prior to submission. Verifying your patient demographic information, your CPT and ICD-10 codes, check for missing charges, missing modifiers, and then your NDC MPI numbers. Your missing charges and missing modifiers are, it's revenue, and losing and not putting your modifiers onto your CPT codes is, again, lost revenue. So making sure that you're attaching appropriate modifiers and making sure that you're capturing all of your charges is important.
One thing, as Himmick is talking, I know that some of the health departments we've gone in, we see that they're not charging for any of the in-office lab fees, like pregnancy tests, dipsticks, and all. If you're doing the service in the office or in the clinic, you can charge for it. But then we have some health departments we go in and they're charging for cultures and things like that that they're really not doing. All they're doing is getting the specimen and sending it out. So you want to make sure, again, this is a lot deeper than this manual is going to go, but you need to do your due diligence of your end. What do we actually do? What we do? And then be able to either put that on a super bill or for a form so that you can be able to check it off quickly and easily and use it as a guide for your providers and for your office staff.
Mm-hmm. After your claims have been submitted, electronic claims have been submitted, verifying that the electronic claim file was received by the clearinghouse, reviewing the clearinghouse report for any claim that did not pass their editing or scrubbing software, checking the clearinghouse for any claims that did not pass their payer denial reports. Paper claims should be printed and mailed on a daily or weekly basis when required by insurance companies. Secondary insurance claims should be processed immediately. After primary carrier claims have been resolved and patient accounts have been updated.
Patient statements, we recommend you do a recycle rather than sending them out once a month. Most practice management systems can be on a cycle. It makes it easier for you to manage. So basically, you're printing or you're electronically sending all your statements once a week from A to Z. You're not breaking it down by alphabet. It will only pick up and submit statements to the patients that haven't received them within the 30-day or 28-day period of time. And we do recommend that, if at all possible, that you do electronic statements, because we're finding in so many health departments, statements pile up. Your system is looking at that you've sent them, but you haven't. They haven't even gone out because someone needs to review them. And so often, the billers, whoever is supposed to be processing the statements, they get very busy, and then they don't do it. So it may be 6 months. Sometimes we've seen 6 months or more that statements haven't even gone out. So by making it in an electronic format, it's much easier to manage. And obviously with the central collections unit and your criteria for sending claim billing over to them, a 90-day period and 3 statements, it's really important, because if somebody prints a statement and it sits there, they've never gotten it. Mm-hmm. So
the next part is making sure that you're set up for EFT and electronic remittance advice. We touched on this earlier. Your ERAs are essentially your electronic explanation of benefits, but having those set up, it reduces your paper and also allows you to see the explanation of benefits much easier in your practice management system. So when looking for a clearinghouse, making sure that they have the ability for this is critical.
And most of your standard clearinghouses do have ERA and EFT, because it's become pretty much for certification, mandatory requirement.
We spoke a little bit about accounts receivables and working your accounts receivables. This is outstanding money that's sitting either with your payers or your patients. All insurance balances that are greater than 45 days should be worked every month. We'll go into a little bit more detail about accounts receivables in the next subchapter.
Administrative reports, obviously they're very important for your billing practices, and the health departments are very familiar with reports because of all of the different programs and different grants and all that you have to have. So we're not going to go a whole lot into KPI reports. Basically, well, it's charges, payments, adjustments, looking at that cycle, looking at, you know, making sure the charges were captured, that type of thing. Okay. Claims. This section, again, we don't want to go in a whole lot of detail with you for time's sake and all, but, okay. This is a little information about how to avoid claim denials, and what we did was just went through and talked about, like we mentioned earlier, about the CLIA number, where it needs to go on the claim, what box, if you have lab procedures being done in the office. And this is a paper claim. Electronically it goes somewhere else. But this would have to be in your practice management system. Prior authorizations, we talk about what box the prior authorizations need to go. NDC numbers, we're showing you how to find the NDC number. If you don't have it, it's, like I said, it's right there on the vial or the medication, the box that it comes in, also on invoices. This is showing you where the NDC number is to go, and you can't express enough about the units. One you probably see a lot is Depo-Provera, which is a birth control. That the code that they use, J050, is for 1 unit. So if you don't put 150 or 103, whatever units that you're actually giving, you're only going to get paid for 1 unit. So we see that a lot. This is explaining how to break down the units and about NDC numbers. Here again about the incorrect number of units. It's such a common problem, that's why I'm bringing it up. Patient account numbers. We wanted, you know, one of the problems with health departments, like we mentioned earlier, is it's difficult for them to decide sometimes when things come through an EOB, a denial and all, what department it was. On the 1500 form, there is a place there for you to be able to put a patient's claim number. Some of the practice management systems automatically default and put a claim number on or an account number on there, but you may be able to distinguish which department, if your practice management system will allow you to be able to put like a prefix XTI or ID in front of it. So it's something you might want to ask when you're setting up the practice management system, if you need that information generated for you. This is an example right here of a patient's account number in this box, and just put an RH, meaning reproductive health, so you know exactly where it would go. We'll go into this just briefly, again, because we're getting close on time, but this is one of the best guides I've found, and this is the National Uniform Claim Committee. This will go through the 1500 form, the CMS 1500 form, which is the claim form that you'll be filing for all your professional component claims. It will go through box by box, what needs to go in each one. Now, there may be payer-specific things. Medicaid and Medicare may not use it the standard, but this is the standard for all your commercial payers as to what's required on a claim and where it needs to go. This is the Maryland Medicaid Comprehensive Guide. And I'm not going to go again into a lot of information on this. This is the most recent one that we could find. But this is the table of contents. Again, it goes into your basic how to file a claim, how to bill, timely filing, and that type of information. And most of the health departments, I believe, already have that downloaded, but just in case we put it in there. And that's a sample claim form. This is a checklist.
And this can be another one of those helpful tools in examining your claims process. We've put together step-by-step on how you can examine how effective your claims process is, updating and verifying your patient insurance coverage and eligibility information prior to each patient visit to ensure that you have accurate information and submit accurate claims to the correct health insurer, preparing your claims in a timely manner, assigning appropriate practice staff members to review health insurer payments for accuracy, really analyzing your EOBs and ERAs for delays, denials, and reductions, keeping copies of your updated contracted fee schedules in order to verify accurate payment, and checking to see if your practice management system allows you to store your contracted fee schedule, because that makes it a lot easier when submitting claims. Reviewing your monthly collection report and EOBs and ERAs for each claim. Having standardized, accessible templates can streamline your claims appeals process for common denials. And we mentioned the claims follow-up log a little earlier, but maintaining a claims follow-up log or having someone responsible to maintain that follow-up log to monitor your practice's communication with insurance payers regarding claims, and especially when it comes to appeals and working denials. Appeal your denied, delayed, or reduced payments until accurate payment is received. Sometimes payers won't pay you the accurate amount, but making sure that that's being monitored and you're communicating with the payers to ensure that you're receiving accurate payment. And holding internal meetings with the revenue cycle team that's involved in claims processing to make sure that you're constantly evaluating your workflow for ways to improve efficiency.
So often when we've gone into health departments, we'll see the physical departments never talk to the front desk people and the front, or the clinical people. So, and they're the ones posting the payments and all. So I can't emphasize enough how important it is for, not to work in silos anymore. We're starting to see all that change in the health departments because they are starting to work more as a team. And like I said the other day when I was at the health department, it was really nice to see that some of the health departments, their particular claims, reproductive health, STI, are starting to work, and not in silos, but actually communicating together. So that's really a great change that we've noticed.
We do hope this shows that the revenue cycle is all connected between the front desk, clinical, and the billing, so involving everyone is important.
And you're going to see common problems, payer denials and all, because across the board for the same type of specialty. We will talk about quickly here. These are the 10 common medical mistakes that cause claim denials. And claim is not specific enough. So ICD-10 came a couple of years ago, and if you're not specific enough with your codes, there may be 10 codes or 20 codes for diabetes. If you're not specific enough with your codes, your claim is going to get denied, and that's one of the most common claim denial reasons. Claim is missing information. If there's an accident, medical emergency, date of onset, if somebody's pregnant, you don't have the due date, those type of things, or authorization numbers, they'll get denied. Timely filing, again, we were saying 6 months for your Medicaid NCOs, a year for Medicaid and Medicare. But Blue Shield, I think, is a year, but some of the payers, they all have different ones. I think United might be 6 months. So understanding your payers and what those timely filing and appeal timely filings are is very important. Let's see. This is all, again, about timely filing, incorrect patient identifier information, wrong sex. We see that a lot of times. On date of birth, name is not spelled correctly. And typically, if the insurance company's card has a name spelled one way on it, even if it's not the right way, they're not going to process it unless it's the way they see it. So you need to make sure the patient realizes they have to update their insurance cards appropriately, or bill that claim under the way the insurance company has, or hold it until they get it fixed. Coding issues, using the wrong codes. There are codes that are bundled, and some aren't. Again, understanding about coding, when to use a modifier.
And also if we talk a little bit about documentation, making sure that there's sufficient documentation that supports the CPT code that we're billing for. If there isn't that documentation, payers won't pay you. So it's important to make sure that the providers are notified and trained on making sure that they document thoroughly throughout the encounter.
Okay. Duplicate billing. Often we see if a claim's denied, the biller will just send it out again. Some payers, like Care First, they want a resubmission of claim with their form if there's a problem. Other ones will reprocess it if you correct the problem, again, knowing your payers. But duplicate billing, just to keep sending the bill out because it looks good to you, you got to investigate a little bit more and find out why the claim wasn't paid. Upcoding and unbundling, that's what we were talking about a moment ago, about some codes can't be billed together because they're inclusive in the services that you provide, and sometimes with a modifier it will be okay. Again, being educated and understanding coding is extremely important, and that's one of the big denial reasons. Documentation, yeah, they will often, payers will say, we're not going to process it until we get additional information or support for medical necessity, and missing referral or authorization. Number 10, services not covered or the coverage was terminated. That's another common denial reason. Okay. Okay, we wanted to talk just briefly about provider payers, portals. Provider portals, the insurance companies, a lot of them are having provider portals because they want you to communicate through them. That's where you can get, without even going through a clearinghouse in your practice management system, you can go directly to the provider portal. So you can actually have the link set up on your computer, and if you're in United, go to United. You can find out insurance eligibility, benefit information, just by clicking on that, signing in. Then there are pre-authorization requests you can do online. You can do direct claim submission, which some of the health departments are having to do because they don't have a practice management system yet. You can do claim tracking, editing. You can do your appeals online. A lot of great benefits by using and signing up with the patient on the provider portal. And this is a document, again, another resource on Medicare enrollment. We also have this when we go into the payers chapter, but we wanted to put it here about claims and how to enroll through PCOS. We know there are some health departments that are struggling with this right now. Medicare is important. You do have more and more patients becoming dual eligible, which means they have Medicare and Medicaid. Medicaid's the payer of last resort, so you have to file the Medicare first. So you want to make sure that you participate with Medicare. It's important. And also when you're trying to do your roster billing. This is just a little bit about reimbursement for labs performed in a clinic. I think we've talked a little bit about this already when we talk about the CLIA and having it, that number on the claim form. And here's additional link for you to be able to go there and get additional information. And this is a little bit about remittance advices, EOBs, appeals, and secondary claims. Again, an educational piece. Some great information about claim adjudication, processing, review, and that type of thing. Wish we had more time to go into a little bit deeper, but we could do a whole webinar just on this. So, okay. Now we go into payments a little bit.
So we talked a little bit about payment posting and electronic remittance advice. There are two different ways to receive remittance advice. One is your ERAs, and the second is your standard paper remit, which is SPR. We do strongly encourage the health departments to use the ERAs. It's much easier and works well with your practice management systems.
And most practice management systems now will electronically post the payment to the system, to the claim line item. You can still monitor and make sure that you agree with the reimbursement as you hold it. But that way it really expedites the payment posting, because otherwise whoever's posting the payment has to manually pull each account up and apply the payment to the correct data service. Doing it electronically pulls the correct patient up in the right data service, because often a human error is pulling it up the wrong data service, the wrong patient, and then it's a nightmare trying to reconcile and to fix it later.
Mm-hmm. So you're saving time, you're saving money, and also that your ERAs are generally more detailed than your standard paper remits as well. So
in some practice management systems, they store, when it comes over electronically, that claim is stored electronically in with the patient's account. So you can click it and update it anytime you want. And also you can use it for secondary claims. So it's really nice to be able to do that.
Just some information on how to read an EOB. It's we think this is a document that lists out all the key components of the EOB and really does have a great kind of overview of the EOB. There is also a sample copy of the EOB on the last page, which can be used to take.
Right. The thing is that each insurance company may have a different format for their EOB. Okay, so this one that HMH is pulling over now is a standard what Medicare looks like. Now some of the practice management systems will pull it out and change them all to this format. And some of them will pull them over exactly the way it looks like when it comes over from the payer. So they do look different sometimes. But the key components of what is supposed to be on the EOB is in that sheet that HMH just displayed to you.
And again, this is just another sample EOB that we.
Yeah, and you can see down, like Medicare, they give the denial reasons, they give the explanation of why the denial. Some of your EOBs do not have it. There's a separate grid. It's on the last page. It's not showing.
When it comes to tracking your denials as well, when you're doing your reporting, this is a good way to really track why your claims are being denied for using those denial codes.
Okay, and there's a sample, another sample of a commercial payer. And we're going to go now, collections and CCU. Let's just quickly talk about that because we still want to get into the medical billing software quickly. As everybody in the health departments probably know, you have a state central collection unit. There are certain criteria that if you have accounts that are 90 days old, that they've received three statements that they're supposed to be referred to the CCU. Plus there's a 17% charge that gets added to the patient's account. They will withhold income tax refunds for patients if this is in that the patient owes money that's in the CCU. So we're not going to go a lot into detail, but we do have the most recent CCU manual. They're working on a new one, and I talked to the people at the CCU unit, and they said they're hoping to have one done by the end of the year to be updated. But as far as it's concerned right now, this information in this manual is how you're supposed to process those delinquent accounts. Okay, this is the debt referral form that you can fill out to send things to CCU, but most of the health departments we found are doing it electronically through batching. This is, early we had the question about discounts and hardship. This is the OIG, Federal Register that explains a little bit more about about discounting and all. Again, we'll provide additional information since it seems to be an interest, but this really does go into the technical legal aspect about discounts to the government. And then here is a sample financial hardship policy. I forgot we put this in there. But again, you'd need to modify it. There is no standardized, form that everybody would use. This is just a sample, example of what you could do. Okay. Okay, we're going to go real quickly to the reports and administration. There are key indicator reports that we mentioned before that to keep the financial awareness about your clinic or your health department. And so mostly just explaining what KPI reports are.
So this document here goes over some of what we've identified as the key KPIs for evaluating your revenue cycle. And without going into too much detail for each of these, we've listed them out here, but we have got more detail in this document. Total charges overall, and if you want to compare between providers, you can run a report by provider. Total new and established patient visits. We've talked a little bit about the accounts receivables, your age accounts receivables, your collection rate, your claim denial rate, which tells you how often are your claims being denied by your payers, and then your payer mix, your payer ratios. But again, there's a lot of great information in this document that shows you how to calculate each of these different KPIs that we've listed here.
And this is a sample of the controls. It's just medical practice internal controls for administration. To compare your in-month collections and that type of thing. Again, it's just another tool for you to be able to use. And the last document we won't go into is if you're interested in outsourcing billing. The last chapter, when we see we do have a couple questions. One is for clients with insurance, and insurance only pays part of the charge. Do we put the remaining balance to the patient and use the sliding fee scale, or is the remaining balance the patient's responsibility if the EOB says copay or deductible? That's an interesting question because, again, we run back into your Title 10 program that you have to bill the least of the two. So if the patient has a deductible or copay that's higher than what they would be on the sliding fee scale, then you can only charge the sliding fee scale. So that, again, is one of those questions. It depends on the program. I wish I could be more specific, and we will go into more of that when we do talk about the different programs.
The next question was, would we be able to get this report card for all KPIs? This will help with developing the dashboard. The KPIs we listed were what we felt were the 7 key KPIs, and we went into much more detail in that document on how to calculate those KPIs, and that can be used as a dashboard. There are more KPIs that we do know of, and we're happy to work with you guys on those KPIs as well. But those 7 were the key ones that really can evaluate your health.
With the health department, you're kind of unique from private practices because you also have reports that you have to give for school-based, STI, the funding for Ryan White, all those different aspects. So especially when you're going into looking at practice management systems, you want to know all the reporting requirements that you have for each one of your departments so that you can make sure that your practice management system is capable of producing and reporting on that information. Also, it may be necessary on the demographic information or in the patient, the EHR, that you ask additional questions that aren't on the standard EHR template. So one of the things as we're working with health departments looking at practice management systems and EHRs, we say, okay, do an evaluation of everything that you do within your health department. Go to your program directors and say, okay, what do you have to report on? They probably won't know just the snap of button, but they will, if you give them time or a survey, they'll be able to come up with a lot of things that you won't miss if you don't do that ahead of time. We don't have but a few minutes left, like 5 minutes. We did schedule this webinar an extra 15 minutes, but I know we're only supposed to do it for 2 hours. So we're going to very quickly go through the medical billing software, a little bit about it, and what we can do on the next webinar, go into a deeper dive with it, so that way, you have additional information. So the first thing we have up here is the medical billing software, which we did talk about earlier, which we referred to throughout the program as a PMS, practice management system. This, like we mentioned earlier, these are the features within a practice management system that you typically see. Some of those are repeated also in the EHR. They kind of cross over.
So we did have the question earlier about the differences between the PMS and the electronic health record. So this document does kind of explain what the PMS software does and what the electronic health record does.
And what a clearinghouse.
And what the clearinghouse does as well. So hopefully this can help answer that question.
And we have a folder on each one of those items. We have a folder about practice management systems, what you need to keep system functionality and features that you should be looking for. Again, the next webinar, we'll make sure we even touch on that a little bit more. Then we have, on top of that, we have, this is something I just want to know. There is a free practice management software. We're not saying it's the way to go, but we're just letting you know it is out there. If anybody wanted to try it, it's through Office Ally. It's not going to be real robust. It's not going to do all the things that you want, but if you're a poor health department and you need something, it's a possibility for you. So we just wanted to provide that information to you. Let's see here. Clearinghouses, again, pick a robust clearinghouse if you can. Sometimes your practice management system, the vendor will tell you that they only use a couple different ones. So compare your prices, look at what features they have. Indion, which is now been bought out by someone else, that's a pretty robust. Gateway, which is now Trizetto, is a good clearinghouse. This is something we did get from Navicure, which is a clearinghouse too. It tells you what you should look for and what features are in a good clearinghouse. There's Indion, which, like I said, just got purchased, but that used to be WebMD. They keep rolling over. Office Ally is one that some of the health departments are using now as a temporary. And also Patagonia, though, use that software. I think there's 6 health departments that are currently using Patagonia software. They use Office Ally as their clearinghouse. You can go on to Office Ally and submit your claims even without a practice management system. You can just key in your charges and all. And several health departments at this time, that's what they're doing. So we provided you a little bit of a resource on Office Ally. Again, not endorsing it, but it certainly is a way to go, even if it's temporarily, that you can do your claims electronically. Electronic health records. Again, we pointing out different things about what an EHR is, and what you want to look for, the certification and all. We will go into more detail in the next webinar on EHR. This is functions and features again, and here's a link for you to be able to go to if you're going to do a deeper dive. And here's a guide. This is from Cardia, again, the great reference tools. And they will tell you, again, meaningful use. They'll talk about all the different features that an EHR should have. And the last one we kind of talked about briefly a few minutes ago.
Yeah, so this is the direct billing. Medicare and Medicaid and many other payers will accept electronic claims directly through their provider portal rather than receiving claims through the clearinghouse that we talked about. The advantages of submitting claims directly to the payer and kind of bypassing the clearinghouses,
It's free.
It's free, and you have the ability to submit claims directly to the payer without needing a practice management system. The service is free. Many PM systems can set up to bypass the clearinghouse, which avoids costs and forward claims directly to the payer. It's faster claim processing and therefore faster reimbursement. It's a much more cost-effective option for a clinic or practice that only submits a few claims to a limited number of payers as well.
The disadvantage is if you don't have it set up so that it electronically goes from your practice management system directly to the payer, then the disadvantage is you may have to key it in separately. And you're trying to streamline processes, but there's a lot that's been changing in the world of submitting claims with the payers just recently. That has changed.
So we've included some information here on submitting claims directly to Maryland Medicaid for those of you that are interested in doing that.
Because you can do that. Okay. That's the log on for eMedicaid. Just showing just a screenshot for you and a little bit more information. And when you sign up for eMedicaid, there's usually an administrator. The administrator will give the rights to the different employees as to whether they can do eligibility, claim status, submit claims, and that type of thing.
And here's a tool for Medicare enrollment and claim submission. It has the guidelines for Medicare enrollment. It's a great document. It shows you how applying for your FPI numbers, enrolling in the Medicare program, applying for enrollment into the Medicare program. Really has a step-by-step process on the application process.
Okay, we have a question. We're going to show, we're pretty much done everything we were hoping to accomplish except not doing a deep dive. But we did have a question. One person wanted to know about where they could get the manual from. And we'll pull that over and so that you can see where you can download it from. This is what we were given from DHMH a little while ago. It may be they're talking about doing it a little bit differently. We don't have any control over how you obtain the manual at this point, but we will get more information and make sure it gets out to you. We also, like I mentioned earlier, the webinar is being taped and will be available probably, they said, April 3rd or 5th. And we'll let you know exactly where it is that you can get the manual from. Let's see if there's any other questions. I think that we've covered everything, and we really thank you for your patience. I know we went over a couple minutes. We tried to talk fast, and there's so much more information we need to go over. The next webinar we plan will probably be in, like I said, in a couple of weeks, maybe the week of April 10th. And then a couple of weeks after that, we'll schedule the live presentation to cover Chapter 4. DHMH will, they'll do a survey to find out what day is better for us to do the next webinar, and we will be back in touch. So thank you all for attending the webinar, and hopefully you can download the full manual shortly.